Today, I'm really happy to be here. I really like talking about these issues. I'm going to be presenting on social determinants of health in marginalized populations. Just to be upfront, I have no conflicts to disclose for the purposes of this presentation. And then just go over sort of what we're going to talk about today. I'm going to really focus this presentation on outlining the structural factors and the systemic drivers that contribute to health inequity, and then describe social determinants of health in that context. And then describe the social determinants of health in the context of marginalization, or how we marginalize populations, essentially. And so this schematic here, which is from the National Academies of Science, Engineering, and Medicine, I think really sort of drives home the point of how we arrive at health inequities. So really we start with structural inequities, and those are the drivers, both in policy and practice, that really sort of influence the distribution of resources or the distribution of health opportunities for individuals. So those sort of the overarching policies that drive those things. I like to think of social determinants of health the way they think of it, which is they comprise basically the playing field or the terrain upon which those structural inequities operate. So if you think about the broad policies and sort of the inequities and policies that drive health opportunities, they create the distribution or allocation of resources or the conditions in which people live, work, and play, or your social determinants of health. By virtue of that and your exposures and your access to those resources, then we have potential differences or systematic differences in health outcomes across individuals or across groups. And oftentimes those health inequities are the avoidable, preventable, frankly, differences in those health outcomes. So this is sort of the framework that we sort of think about when we try to explain how do those structural inequities lead to those health inequities. So to just kind of get a little bit more concrete with it and provide a concrete example of how this might work is looking at an example which is related to racism. So looking really at structural inequity in action. So when we think again about structural inequities, it's those practices and policies that potentially lead to unequal distribution of resources and access and power. Racism is one of those things. Other things include classism, ableism, xenophobia drive some of those policy decisions. So if we look at this example, which is racism, it's basically a social ecological model of racism. We look at the impacts of racism at different levels and then how those different impacts basically coalesce or work together to really influence outcomes. And so the example here is, we work through sort of the systemic, community, institutional, interpersonal, and then even the intrapersonal level. So thinking again, largely, and then going into the center. So more broadly, systemically, we're talking about immigration policies, incarceration policies, racism or inequity, and the criminal justice system. Those are those big policy decisions that have impact on the daily lives of communities, and particularly communities of color. At the community level, that then leads to differential allocation or distribution of those resources. And you sometimes see that in terms of school or class segregation at schools. Institutional level, you see hiring practices, even patient care practices at an institutional level that sometimes are impacted by things like racism bias. At an interpersonal levels, you're sort of more sort of concrete, sort of person-to-person overt discrimination or implicit bias that occurs between individuals or between groups of people. And then interpersonal level is some of that internalized racism that some of us experience and some communities of color will experience. Internalized racism, feeling like individuals' inequities are sort of the standard or the norm for life in that community, and then getting accustomed to the idea that this is what it's supposed to be like. So sort of that internalized racism in that respect. So again, racism is sort of an example of something that occurs at the structural level, sort of that broadest level. And then now we're talking about how it sort of manifests. And again, social determinants of health are thought to be sort of the terrain or the playing field upon which those policies sort of manifest, if you will. So what are the social determinants of health? I'm sure all of you sort of heard that term. There's a couple of different definitions out there. I find that this one is, the most sort of to the point, sort of concrete. They are the conditions and environments in which people are born, live, learn, work, and play. And that affects a range of health, functioning, and quality of life outcomes and risks. So those conditions in various environments and settings have been referred to as the place. So it's the place that someone lives. But place is used sort of broadly in this instance. It's not just referring to physical space and physical place, but also means the patterns of living or patterns of life that are associated with those places, patterns of social engagement and security and well-being affected by where people live. And then resources that enhance quality of life can have a significant influence on those population health outcomes. And you think about how resources are distributed amongst communities, we know that there's unfair, unequal distribution of those resources. So then thinking about how communities themselves reflect that unequal distribution of social determinants of health, which then leads to unequal health outcomes for those particular communities that are more at a disadvantage. So when we think about sort of the Centers for Disease Control or sort of the World Health Organization construction of social determinants of health, they really are sort of broken down into these domains: neighborhood and built environment, health and healthcare access, social and the community context, education or access to education, and then economic stability, which includes employment opportunity, things like that. Those are the main clusters, if you will, of social determinants of health. I really like this schematic when we think about social determinants of health, because I think this drives the point home even further when we talk about how do we create healthy individuals and healthy communities. So traditionally in medicine, we have sort of had this perspective of you treat the individual when they come into the office, right? They come in for a concern, you treat the concern, and then they're sort of on their way. So we try and make them healthy at that individual level. What we have learned is that really creating healthy individuals, or the individual itself, is the tip of the iceberg. And so really, we can't create healthy individuals without looking at all of the different levels that sort of play into an individual's health. So really in this schematic, healthy people are the tip, and then you notice below healthy people are things like healthy communities, healthy environments, and healthy societies. So the idea being we cannot have healthy individuals unless we take care of the communities, societies, environments in which these people live. And so on the sides of the sort of the triangle, if you will, on the sides are things that allude to those social determinants of health: neighborhood safety, collective efficacy, environmental quality, income security, mental health services, prevention services, which is a big deal in terms of making sure that our population stays healthy. A lot of people don't have access to preventive care. Healthcare access, child development and education, food insecurity or food security, which is a particularly big issue right now in the midst of the COVID-19 pandemic, built environment, and also highly, right now in the national discourse, things related to discrimination, racism, and minority stressors. So unless we pay attention to those things, we are unable really to treat an individual and maintain their health, is essentially what this graphic is trying to depict. So when it comes down to it, this is even more concrete, I think, in terms of breaking down what are we treating when we're treating an individual. Well, if you look at an individual's makeup, when we think about health, we think that about 40% of an individual's health, or 50% actually of an individual's health, because it includes physical environment, is traced back to their zip code. So there is the saying of like, it's not about your genetic code, but rather your health is more dependent on your zip code. And this sort of bears that out, which means that about 50% of your health is traced back to factors that likely you don't necessarily have control of because it's your living environment, or by virtue of the context in which you live, there are factors that are likely out of your control. If you add on to that healthcare access, which sometimes again is determined by socioeconomic status and access to health insurance, things like that, that's an extra 20%. So really we're only talking about 30% that is within an individual's control, so to speak, and I put that in quotation marks, but that would be your health behaviors. So tobacco use, diet and exercise, alcohol use, health risk behaviors, basically. And again, I put that in quotations because I don't want it to be, the thought is that in and of itself is just in your control. If you look at diet and exercise, tobacco use, we know that there's a lot of external factors that also influence whether someone engages in those behaviors. Targeting messaging for tobacco use, diet and exercise, whether you have access to healthy food, you live in a food desert, whether you have the ability to exercise in a safe manner in your environment. So there are still drivers of that that are not necessarily just an individual's choice. And so much of what makes up an individual's health is determined by factors that are beyond their control and oftentimes tied back to where they live, what they have access to, and what their resources are. So by virtue of that, the individuals that we were just talking about in terms of, communities that are at a disadvantage, they are at a disadvantage much because of marginalization. And so who are marginalized groups? Marginalized groups are groups and communities that experience discrimination and exclusion because of unequal power relationships across economic, political, and cultural dimensions. So it's basically individuals who don't represent the reference group. And so when I say reference group, who is the reference group? Frankly, reference group in this society are heteronormative, cisgendered, white non-Hispanic individuals. You can get bigger from there. No disabilities, able-bodied, you can broach largely, but those are the referent groups. Individuals outside of those reference groups tend to belong to a marginalized group, likely in some capacity, because they represent a minority or they represent a minority perspective. So how do we marginalize groups effectively? Essentially, how does that happen? Well, by virtue of those policies, those structural inequities, biases and policies and practices, racism, discrimination, things that are acting or that manifest at that larger societal level, we create margins or boundaries, and we push individuals to those margins or boundaries. We push them to the peripherals of society. And so, yes, we're talking about minority groups, but we're also talking about populations that we don't necessarily consider minority groups, if you will. So individuals who have once been incarcerated, they are pushed to the peripherals of society based on policies in terms of being able to rejoin the workforce, voting rights being reestablished. So we push them, we have policies and things in place that continue to push them to the peripherals of society. Individuals who are recovering from substance use or are in active substance use recovery, they also are pushed to the peripheries of societies based on different policies and things like that. We create, by virtue of that, we create these in-group and out-group dynamics. And so certain groups are thought to represent the out-group. They're thought to represent groups that have to sort of assimilate to whatever is happening or whatever is in existence for the in-group. But the problem with that is those policies don't help those groups the way that they do for those referent groups that I just mentioned. And then we maintain and enforce these marginalization. We maintain and reinforce it by maintaining the status quo, by not changing our policies, by not adapting policies and procedures and protocols and processes to ensure equity. We maintain that status quo and we maintain those power dynamics. And there's some thought to say that by virtue of doing that, we keep certain individuals or certain groups as the referent group. And because we try to maintain that on some level, the differential access to opportunities, the differential access to power is something that people actively try to maintain. So this sort of just describes that whole marginalization process, if you will. We all have social positions or social identities or social locations. As I mentioned, we belong to certain groups, if you will. Depending on what group you belong to or what group you identify with, the social position or social construction for that group has a place in society. It just does. Every single group has a place in society. And it's dictated by the boundaries and the policies that we've created for society. Depending on your social position, you may experience increased marginalization on your left or increased inequality because that inequality gradient does increase as your social position gets further and further away from the mainstream or what I refer to as the referent group. So you're pushed further and further away from that peripheral, into the peripherals of society. And that distance can be both objective distance and also perceived distance. So again, if we go back to that one graphic that I talked about in terms of the interpersonal impact of racism, that internalized racism, that perceived distance, because of the experience, is also something that plays a great deal or plays a big role in one's health and one's mental health. So even if it's not an objective distance, that perceived distance is quite important as well. And so how does this sort of play out day to day? Well, we basically live in an ecosystem, a complex ecosystem of persistent inequities. At the largest level, we have, again, racism, discrimination, and policies that then create additional stressors for our minority groups. So racism impacting our communities of color, xenophobia impacting our immigrant, refugee communities. We also tend to congregate communities of color in certain areas or in certain geographic locations. Part of that has been driven by historical policies that have led to discrimination, such as redlining. So we know that the biggest way that one accumulates wealth is through property ownership. It's the quickest way and the best way to accumulate wealth for an individual or for a family. But we have had a history of redlining whereby communities of color, particularly Black and African Americans, were unable to access loans in order to purchase homes and or unable to access land in order to purchase land in a way that would help build their wealth. And so that history of redlining has created a big racial wealth gap when it comes to wealth for African Americans and Black individuals compared to white non-Hispanic individuals. And in those, by doing so, we create siloed or congregated communities where communities of color do tend to congregate. And then we historically, as a society, have also congregated environmental hazards in some of those communities, making these communities more prone or potentially more exposed to environmental hazards that then create opportunities to develop pre-existing conditions, diabetes, obesity, asthma, COPD, by virtue of where they live and by virtue of some of the policies that have led people to establish a life in these certain communities. We also know that socioeconomically, communities of color, Black and Hispanic individuals in particular, their median income is lower than our white non-Hispanic individuals. You've seen probably some of the data on equal pay and how, certain individuals, it takes so many days in the year before they earn the same amount of money that would be allocated to someone who is of white non-Hispanic background. And so we know that that difference in median level outcome is influenced by things like race. And then if you put all of that together just in terms of structural barriers, it's sort of what you face every day: issues with transportation, issues with neighborhood safety, issues with food security. Those are all the things that sort of day to day you may experience as a member of a disadvantaged group. And so this ecosystem of persistent inequities, as complex as it is laid out here, is much more complex, obviously, in reality, but you then get a feeling for how difficult it is to have individuals who experience such a disadvantage, how they are both, one, likely to experience negative health outcomes, both physical health and mental health outcomes, but then how do we change the outcomes for them? There's a lot that has to go into that in order to change those outcomes. So I want to get back to marginalization because there's a key point here that I want to highlight. I'm not going to get into it in detail today because it's beyond the scope of this presentation, but certainly it's an important point. So marginalized groups are groups that are unable to access social determinants of health in an equitable manner and experience additional inequities, including social exclusion, that may result from historical and contemporary discrimination and trauma. So I want to make sure that that's added on because that's a separate issue in addition to being unable to access social determinants of health equitably. This intersectionality, and that's the key point I want to highlight, is intersectionality, creates unique experiences of inequity and injustice that poses challenges at all levels. Intersectionality is a complex construct. Again, it's beyond the scope of this presentation, but I really want people to start thinking about, when we think about inequity, we think about unique inequity experiences by different groups because of intersectional oppressions. There are systems that oppress groups and individuals, and they do so in an intersectional manner when you belong to some various groups that have a low social positioning or low social identity allocation. So what do we do with all of this information? So I've just sort of shared, what sort of drives inequities, what drives social determinants of health as a factor that leads to health inequities. One of the things that I'd like to just sort of highlight is adopting sort of these frameworks of social justice and health justice in terms of our work. So social justice is basically the premise that these unequal outcomes in health are avoidable, they're preventable, and they're unfair because they actually are avoidable and preventable. And as such, society should really work to ensure that every individual has the capability, the optimal capability to be healthy. And that includes distributing social determinants of health in a way that every individual has the same possibility to lead a healthy life as every other individual. Health justice sort of takes that same approach and says, in doing that, we need to basically integrate social determinants of health into policymaking, and that policies, laws, and social structures should be designed not only to address and prevent health inequity, but frankly, maintain health equity for individuals. And I think, I believe it sounds like, I think I looked at the schedule, and it sounds like there was a recent, I think Nicole did it on structural competency, presentation on structural competency. And this goes a long way into sort of thinking about those issues too. Structural competency sort of built on these principles. So social justice, or the main principles are access, greater equality to access of resources, goods, equity, meaning overcoming unfairness caused by that unequal access, rights being that everyone has equal effective legal, political, and human rights. And then participation, which I think is really important, which basically says that opportunities should be expanded for everyone to have the ability to participate in governing or decision making that affects their daily life. And so, yes, we can talk about that in terms of policies and advocating for policy change. But I'd also like to distill that down to how we make decisions for programs in communities. So there are a lot of efforts in terms of trying to develop programs that will help disadvantaged communities have better access to resources and things like that. And the key here is that those same community members should be part of the process in terms of developing those programs, that they should have equal opportunity to participate in those decision-making processes about things that would benefit their community. So just a more concrete example of how do we apply social justice when we're talking about the current issues, COVID-19 and racism. So first and foremost is always understanding the far-reaching implications of the crisis on vulnerable populations. We know everyone is impacted by COVID-19, but our vulnerable populations are impacted in a unique way, as I mentioned. And so really understanding what that looks like and what that experience has been. Focusing on systemic and structural change rather than individual level change, that's still good, but really largely speaking, we want to try and solve the larger picture, and advocating for marginalized communities and those most vulnerable. Health justice principles really focus on equal right, equal opportunity, and equal treatment. Those are your key principles. And again, how do we apply this, or what does this look like in terms of the current issues? In terms of COVID-19 and racism, responses must address social determinants of health. And for racism, must address historical issues of trauma and the lasting impact that that has had on generations of Black and African Americans. Supports provided for mitigating interventions and strategies. So when we think about COVID-19, there's a lot of communication around mitigating strategies and what we need to do to prevent the spread of COVID-19. But with that said, for a lot of our marginalized or vulnerable populations, they may not be able to engage in those mitigating strategies the way that others can. And so what have we offered them? Have we provided the opportunity to isolate members of a family if they live in a multi-generational home? Have we allowed, or do we have policies to protect essential workers so they can stay home from work if they are sick? Those are the kinds of things that have to be in place. We can't say we recommend all of these things and then not put the supports in place, because then it leads to unfair engagement in those strategies. Folks are not able to engage in those strategies, thereby putting themselves and their families more at risk. And responses must address immediate needs and root causes. So we can't just focus on immediate needs, although those are critically important, but looking at sort of the root causes of what created the unfairness or the inequitable sort of outcomes to begin with are things that we need to pay attention to. So I provided some references for you all just to go along with this presentation, and then this is my contact information. I'm always happy to talk about any of these issues, and certainly I tweet about it a lot, so if you are interested in following me on Twitter, feel free. I tweet about these issues sort of constantly. So that is it. I don't know if we have time for